Hello students, here I will give a brief note on the esophageal cancer. By listening it you will be able to understand the topic and be able to answer short questions and solve MCQs in examination. Epidemiology and Aetiology. Esophageal cancer is the 8th most common cancer worldwide, with squamous cell carcinoma and adenocarcinoma being the predominant types. The incidence of adenocarcinoma has now surpassed that of squamous cell carcinoma in many developed countries. Genetic predisposition, smoking, and alcohol consumption are key risk factors for squamous cell carcinoma, especially among individuals with genetic polymorphisms affecting alcohol metabolism. Environmental and dietary factors, including nitrosamines, hot beverages, and deficiencies in specific vitamins and minerals, also play a significant role. Clinical presentation and pathology. Esophageal cancer often presents late, leading to a poor prognosis. Progressive dysphagia is the most common symptom, progressing from difficulty swallowing solids to liquids. Adenocarcinomas typically occur in the lower esophagus and the oesophagogastric junction, OGJ, while squamous cell carcinomas are more common in the middle and upper parts of the esophagus. Both types can metastasize early to regional lymph nodes and distant organs. Diagnosis. Diagnosis involves endoscopy, barium studies, and imaging modalities such as CT scans, and PET scans. Early cancers are often asymptomatic and detected incidentally during endoscopies for other conditions. Advanced cancers are easier to diagnose due to more apparent symptoms and visualization on imaging. Treatment. Treatment depends on the stage of the disease and the patient's overall health. Early-stage cancers confined to the mucosa may be treated endoscopically, while more advanced stages may require surgery, chemotherapy, or palliative care. Multidisciplinary team discussions are essential to determine the best management approach for each patient. Pre-treatment evaluation. Endoscopic resection is advisable for uncertain T1A and T1B disease diagnoses. If the resected specimen is T1A with clear margins and no lymphovascular involvement, the endoscopic treatment is curative. If the tumor is deeper or margins are not clear, further therapy is required. Surgical indications. Surgery aims for potential cure in localized tumors confined to the esophageal wall or with limited regional spread. R0 resection, complete removal of tumor margins, is essential for long-term survival. Surgery alone is typically indicated for advanced cancers unlikely to be cured by endoscopic treatment, T1B, T2, N0. Multimodal treatment is preferred for more advanced disease, greater than or equal to T3, N+. Patient preparation. Assess patients for operative risks and optimize their physiological status. Conduct cardiorespiratory assessments and promote cessation of smoking and alcohol. Utilize chest physiotherapy and incentive spirometry preoperatively. Nutritional support may be necessary, especially in patients with significant weight loss. Surgical techniques. The choice of surgical approach depends on the tumor location, lymphadenectomy extent, and reconstructive technique. Techniques include thoracoabdominal incision, Lewis-Tanner procedure, McEwen esophagectomy, and transhiatal esophagectomy. Minimally invasive approaches, combining thoracoscopy and laparoscopy, are increasingly common. Lymphadenectomy ensures adequate staging and disease control. Two-field dissection includes mediastinal and upper abdominal lymph nodes. Three-field dissection includes cervical lymphadenectomy and is often used for squamous cell cancers. Reconstruction, gastric conduit is the common choice for restoring intestinal continuity. Alternative options include colonic interposition when the stomach cannot be used. Perioperative care, follow enhanced recovery after surgery, ERAS, protocols to improve outcomes. Key elements include carbohydrate loading, avoiding prolonged fasting, and early feeding. Management of complications. Common complications include atelectasis, pneumonia, atrial fibrillation, recurrent laryngeal nerve injury, anastomotic leaks, and chylus leaks. Treat complications with appropriate antibiotics, nutritional support, and, if needed, surgical re-intervention. Multimodality treatment. Neoadjuvant therapy, chemotherapy or chemoradiotherapy, is often used for advanced disease. Perioperative chemotherapy is commonly used for esophagogastric junction, OGJ, cancers. Immunotherapy is a recent addition to treatment options. Palliative care. Focus on relieving symptoms such as dysphagia. Self-expanding metallic stents and other endoscopic methods can provide immediate relief. Chemotherapy, radiotherapy, and immunotherapy may help manage symptoms and tumor progression.